Good afternoon and welcome everyone to our HSDM Global and Community Health Seminar Series. It is my honor and privilege to introduce today's esteemed guest, Dr. James O'Connell, who is president of Boston Healthcare for the Homeless program. Dr. O'Connell is somewhat of a legend around town. He graduated summa cum laude from the University of Notre Dame and then received a master's degree in theology from Cambridge University. He then graduated from Harvard Medical School and completed a residency in internal medicine at OGCH. In 1985, he began full-time clinical work with homeless individuals and became the founding physician for Boston's Healthcare for the Homeless program. Today, that program serves over 13,000 homeless persons each year, has 2 hospital-based clinics, one at Boston Medical Center and one at MGH, and in more than 60 shelters and outreach sites across Boston. He also, with colleagues, established the nation's first medical respite program for homeless persons, as well as a 25-bed unit in the Lemuel Shattuck shelter. The program now provides acute, subacute, pre- and post-operative care, palliative and end-of-life care in a freestanding 104-bed Barbara McGinnis house. Working with the MGH Laboratory of Computer Science, Dr. O'Connell designed and implemented the nation's first computerized medical record for a homeless program in 1995. So he really has, with his colleagues, revolutionized care for homeless individuals and how we as a community of providers think about how we care for individuals who are homeless. He has been recognized by the Robert Wood Johnson Foundation, by the U.S. Department of Housing and Urban Development. He has edited several books, including Healthcare of Homeless Persons, a Manual of Communicable Diseases and Common Problems, and his articles have appeared in numerous journals. He has also been featured on ABC's Nightline and in a feature-length documentary, Give Me a Shot of Anything. Dr. O'Connell, welcome to HSDM's Global and Community Health Seminar Series. We are very much looking forward to today's presentation and conversation. And as Dr. O'Connell speaks, he has told me that he is happy to accept questions from the audience while he was talking. So please don't hesitate to put your questions into the chat during the presentation, and we'll certainly have time after the presentation for additional questions. Thank you.
And thank you, Jane, and to Christina for making this all so smooth for me. I really appreciate it. And I'm honored to be here virtually, although I'm looking forward to the days when we will all be around the same table again. But if what I thought I might do, and please, I mean that if you have questions, I'd love to get a discussion going, but I, like all nervous doctors, I've got slides to show you and I can interrupt those at any time or skip them anytime. But let me just start with those because they give you a little bit of a background to where we were. And if I can conquer technology, I'm going to share my screen with you and hopefully get this. So sorry, let me go to, you guys would do this all much better than me. So just a quick background on how I got to be here, okay? And it turns out I was, you know, I went to HMS and then I trained in medicine at Mass General, and I had decided during medicine that I really loved end-of-life care and oncology. So I was going to do a fellowship. And in the middle of, or near the end of my last year of residency, the city of Boston got this grant from the Robert Wood Johnson Foundation, which was an attempt to try to integrate the care of homeless people around town into the mainstream of our healthcare systems. And this would be in 1984, 85. And right about then was when this modern age of what we would call homelessness as we know it now. It had been very different prior to that. But this was the beginning of all of that. It was all sorts of changes going on. There had been a recession. There had been a sort of cities were getting gentrified. The amount of money going into public housing and poor housing was going way, way down in response to the recession. And the deinstitution of folks who had suffered from severe and persistent mental illness from the old hospitals, which were closed, and they ended up on the street. So there was just a ton of people coming to the emergency rooms back in the mid 80s who were homeless. And that new wave is what the Robert Wood Johnson Foundation was doing. And now it turns out I have to hope I can do this. So in Boston, there was a coalition of stakeholders who the mayor had gotten together by requirement, by the way, from the foundation. And these were homeless people. This is a picture of them several years after 1984, but they got together and they decided how they wanted to be handled. So everything I tell you today, okay, either comes from the nurses who taught me at the shelters or from the people themselves. And of this group of people, we've had a growing consumer advisory board. And just to frame shift a little bit, and 5 or 6 or 7 of them, depending on what's going on, are on our board of directors. So I'm in this interesting world where we've always been told what to do and directed and governed by the people we serve. And it's been a really interesting experience that I'd love to share with you sometime, but it's been the best thing that ever happened to us. So what they decided was they wanted continuity of care. They were sick of fragmented stuff. They thought their lives are full of loss, full of fragmentation. And the last thing they wanted in their healthcare was more fragmentation. So they wanted full-time people. That's why I got recruited by MGH, who was trying to contribute a full-time doctor to this program, and they couldn't find one. So for those of you who go on to do residency, or if you've already done it, you know when your chief of medicine calls you into the office, all questions are rhetorical, and you just say yes if you value your career. So I decided to do this for a year, just to let you know, this was not in my plan, life plan, journey, anything. But I thought it'd be a great year to give back. And I had gone to school in the 60s, had this late 60s consciousness that I was really hoping to solve. And so this was a chance to give back. And the plan was they wanted doctors and nurse practitioners and PAs to work in teams, get out of the hospitals and come and work in the clinics where homeless people could access them easily. They found that when you're on the streets and walking around or in the shelters, making appointments at the intimidating places like hospitals almost never happened unless they were at that time. If an appointment was made 2 weeks down the line, nobody ever made it. And that was frustrating the hospitals, particularly frustrating the specialists. I'm sure the dentist and all of the oral health folks were completely frustrated by that. So the goal was, let's get us out to where they are. And so this is Pine Street Inn back in 1985. And so my July of 1985, I finished in the ICU at Mass General and went 6 blocks down the street to the clinic here. I thought, how tough can a shelter clinic be if you've just finished doing the ICU for a month? And it turned out to be pretty challenging. But there were 800 people sleeping at Pine Street Inn back then, many on the floor. And it was in the early wave, this early wave of homelessness, and they were exploding. And I remember walking in and there was a nurses clinic there. They've been going for about 10 or 15 years. I don't know if there's any nurses out there in the audience, but if there are, this is basically a tribute to all of you because everything we learned from the nurses. The clinic there was the only independently licensed nurses clinic in the country. They were on the cover of the American Journal of Nursing. That very year, I jumped into the clinic thinking they were going to be thrilled to have a doctor. I have an older sister who's a nurse, so I know that nurses are not always thrilled with us doctors. But anyway, what I had to do, and this is a very long story, and I'll make it very short, they didn't trust anything I was doing. They thought I'd been trained wrong. I worked too fast. I was too quick with people. And they said, look, if you're going to make any difference in the lives of homeless people, you've got to slow down. You've got to get to know them. You've got to earn their trust. And that takes a lot of cups of coffee. It takes a lot of talking, a lot of sharing of your own information before they begin to recognize you as there to help them and not there to take them away. And the most effective thing the nurses did was they soaked everybody's feet at nighttime. And my job for the first 2 months was to not be a doctor, but to soak feet. And I could wax eloquent about how important that was in my training, because it really did teach me to, one, not invade the private space of the people I was taking care of. So I was not the length of the stethoscope away, but I was down at their feet. And that flipping of the power structure turns out to be incredibly powerful. The nurses always called everyone by their names. And I realized that many people wander the streets for days, weeks, and no one ever says their name, certainly not with any dignity. So the nurses were brilliant about inviting people in to be served, never pushing too hard, just asking how you can help. And so I did that for 2 months. That was my apprenticeship. And I just wanted to share that with you because it was, I kept thinking I should be in my fellowship right now. And here I am, Pine Street in probably the smelliest room you've ever known, soaking feet for 2 months. But as I've said before, it was really one of the best things that ever happened to me. So the other place that I had to go was Long Island Shelter, and that was the city's new shelter. It was out on an island in the middle of Boston Harbor, placed there because the mayor couldn't find a community in the city where he could open a shelter. And Pine Street was so full, they needed to open a city shelter. So he did it on an island And the other days we had inpatient clinics at either Mass General or Boston Medical Center, which was Boston City Hospital in those days. Long Island Shelter, but I'd never been to Long Island, by the way. This is the shelter building. It's the old TB treatment center for the city of Boston. It was out on this island, so that it was open to fresh air. But you can see how beautiful it is. That you look at downtown Boston. These pictures are now 40 years old or something like that, so I apologize about the quality. And this was looking out the back door of the shelter where the buses would pull up and let people out. And that dock was where the residents in the old days there was no access except by boat. And they would come and spend their 30-day rotations at the chronic care hospital that used to be on the island and then go back after 30 days. There was in 1935 a bridge built, which becomes very controversial later on. But on the island was the first time I ran into the oral health issues. And I'll never forget this. There was this fabulous dentist who worked with us, and he had one chair out at Long Island in the old hospital grounds. And he was there every night I was there, and we couldn't get anybody to come see him. People were just not interested in going to the dentist. And I kept thinking, I'm not always excited to go to the dentist either, so we have to work on this. And I'll never forget, this was a man I had seen that at Long Island Shelter, and he has gingival hyperplasia from Dilantin. Dilantin was used much more frequently back in those days, and we used to see this relatively commonly. But so he became so frustrated that he couldn't get people to come that he found this man, a man who was a leader of really a wonderful kind of gang of really lively homeless people. This man's teeth had been broken and all that. And he looked at him and he said, I can probably help you with that. And the guy looked at him like he was a little bit crazy, but he said, okay, doc, let me try it. So he took him and he just did a series of bonding these teeth. And I'm sorry about these old pictures, but this is what his teeth looked like after the bonding. And this man went out to all his friends. And I tell you with no lie, the next night that this dentist came in, there were 200 people on the list to see him. So we learned that word of mouth and tender care is what really made a difference. And we also started to realize at that point that every homeless person is in bad need of dental care or oral health. Virtually none of them have had an opportunity to have regular dental care. Most have not seen dentists since they were children, if at all. So the state of people's mouths is really quite extraordinary. And as it turns out, and you know this far better than I, the mouth is kind of the entryway to the rest of health. And when you don't have good oral health care, you are looking at many, many other problems developing. So we learned early on, we were only as good as the oral health care we could provide, and that became our challenge. The other thing that the homeless people asked us to do was open up a respite program. We didn't know what that was because this was the first time anyone had said it, but they were mad at us at the doctors, and they were mad at the hospitals because when they came in very sick, had whatever it was that was going to go on, and then were ready for discharge, they would be discharged back to the streets of the shelters where they had to walk around all day. Remember, the shelters don't let you stay during the daytime, you have to walk. And so they were furious and said, we need a place to go just like other people can go home with a visiting nurse and a home health aide and family. So we opened in the September of 1985, so this is quite a while ago now, with Governor Dukakis giving us space in the Lemuel Shattuck Shelter, which was a state public health hospital. So we had this 25-bed unit back there where we could take people and provide 24-hour care for them. And it was a little bit lazier back then because people could stay in the hospital much, much longer than they can stay now. And I could go over that a little bit. I'm horrified. When I was a senior resident, just so you know, if you came in for a cabbage at Mass General Hospital, your average length of stay was between 4 and 5 weeks. Okay, now it's about four days, right? So during that time of changing the venue for most acute and subacute care for the vast majority of us, homeless people really got caught in a gap, and respite care, which is this program, became more and more critical. About that time, I just wanted to share with you, I'm sorry, let me show you. So the kinds of things we would see then would be this man who has just bad venous stasis, and his skin keeps breaking down. He ended up in and out of the hospital on IV antibiotics for his infections. And we realized we could get him over to our respite program and really take care of that wound and prevent him from going to the hospital. And this woman, I threw in there because you would enjoy this, I think, she came in one night, she has relapsing polychondritis. And you can see the cartilage in her ear and the bridge of her nose is all gone. And it turns out the cartilage in her trachea is also really fragile. And she would frequently have at nighttime respiratory arrest because she couldn't breathe through her trachea. And we learned with the right equipment, we could keep her out of the hospital and safe in our respite program with the right care. So those are the little things we were doing until two things happened right in 1985 for us. This man came in September of 1985, and he turns out to have HIV nephropathy. His kidneys have failed from AIDS, and he's on ambulatory peritoneal dialysis. Had been sent out of the hospital because they said you can do that at home. He had no home. But he was the first homeless person that we knew of in Boston to be diagnosed with AIDS. And this was in September, early September of 1985. And within weeks, we were deluged with people with AIDS. And the first case of AIDS that I had seen was in 1982 when I was an intern at OGCH, but it had not reached the homeless and poor community yet. And this was in 1985 when it started to be there. And it was, I thought the world was coming to an end. Everybody, as you know, back then died, except for those very few long-term non-progressives who we didn't even really know back then. We had no treatment. And this really began to define our respite program. It became very much an AIDS unit. And we eventually had to move out of the shelter, moved into what's called we called it the Barbara McGinnis house at this point, which is a respite, became a freestanding respite, where we could go up to 90 beds and take care of the increasing need. We also had an outbreak of 60 cases of multi-drug resistant tuberculosis. So we had we were sort of, I think of ourselves as conceived in this dual epidemic of AIDS and tuberculosis, much like what we've seen with COVID, although back then the consequences were quite severe and the complications are way, way intense. I point that AIDS issue out because that was sort of the defining moment in my early career. And it taught us how much we were all working together. You probably know all too well that oral leukoplakia was one of the early signs of immunocompromise. And we started realizing we needed to work ever more closely with our dental colleagues. And we joined in a clinic at Boston City Hospital where all of us worked in exactly the same unit. So there was the dentist, the psychiatrist, the neurologist, the oncologist, the ID person, and us, the primary care people, working completely together. So if there was a silver lining to AIDS, it was that we realized we had to work together. It was the only way to go. And so I can't tell you how important and critical oral health was to those days of AIDS. And just to share with you, in those days, we didn't have a place to, to really deliver care. So this is Al Bolden, who on the right, excuse me, who is our dental director, really wonderful human being, had come through Harvard School of Dental Medicine. And he figured out how to get these portable chairs and portable stuff. And we started bringing portable chairs to shelters all over. And he was quite amazing. This is Al hard at work in one of his, and this was at St. Francis House, which is one of the shelters. And then when we moved into our new building, we were able to actually, with the help of Delta Dental back then, have a really nice one-room operatory and just a great staff, including residents from Harvard School of Dental Medicine and from BU. So that really upped our ability to deliver some dental care. Although, as I'm sure you all know, it was just a drop in a bucket for what the need was. The need is huge. And we had to learn, as I think I was speaking with Jane earlier, we had to learn that once you got somebody in the chair, you couldn't say, okay, we'll do this now and come back in a week, and then we'll do more and come back in a week. You had to do almost everything you could while they were in the chair because you weren't sure you could get somebody back. So the way we had to structure appointments changed completely because you had to know when somebody's in the chair, that may take an hour or two before you can have the next appointment. So with only one chair, that was a big challenge. Our dream was to figure out how can you expand a little bit. And we, in 2008, finally moved into the pressure on the respite program was so intense from the hospitals that we moved into the old Mallory Institute of Pathology. If any of you know Boston City Hospital, now Boston Medical Center, but this was where the pathology department for Harvard, Tufts, and BU was. when Boston City Hospital was shared by all 3 medical schools. But anyway, we now have 104 beds in this building, along with a really nice integrated medical and mental health behavioral clinic. And we have a pharmacy, we have offices, the upstairs respite with lots of things going on. And we also have been able to, let me see if I can get some more pictures here. We've been able to, not sure why it's not going, hold on, I'm so sorry. Let me see. So we've been able to do things like have specialists come and see people while they're there. This is Ernesto Gonzalez, who is a dermatologist who's been a mentor and a teacher of mine for years. He has been coming for about 30 years with residents to do derm clinics at our respite programs. And as you can imagine, like with oral health, everybody has been exposed to all sorts of stuff. And the rashes and the pellagra, the vitamin C deficiencies, all that stuff manifested in dermatologic issues. And as you know, AIDS has all sorts of complicated dermatologic issues. So Ernesto really guided us through that. We also, in a place like that, were able to do something I wanted to share with you, which was my passion, was end of life care. So these are 2 people at our different ends of the life spectrum. Tommy on the left is 84 and dying of a neurological cancer, and Byron on the right has got lung cancer that has now spread to his head. And these are the days when he had no biologics that would work for him, and so he was really at the end of his life. So the 2 of them really were roommates, and we were able to provide relatively comfortable end of life care for 2 people who had no family, no money, and no one in their world. So while it was difficult on the staff and difficult on everyone, it was in many ways gratifying that there was finally a safe place for people to die surrounded by people that really care about them. But this was the other thing. We were able to open a new clinic with the help of a lot of wonderful support, including from Delta Dental back then. But this is Colleen Anderson, who is our dental director now. She is phenomenal. She went right through Harvard School of Dental Medicine and came and started working with us. And she's been with us about 15 years now. And she's spectacular. But we have now 6 operatories, about to expand to 8. And this is our sort of key dental staff now. And we have fellows from Harvard School of Dental Medicine who come and spend, at least prior to COVID, I don't know how we're going to do things now, would spend 3 to 6 month rotations down there. And I think, just to put in a plug, I think they really liked it, because when you go and work in our clinic, you see things you wouldn't see almost anywhere else. So most of the students have loved being there just because they get that opportunity to see things. And working with these 4 is just a dream. And let me, I don't want to be talking too long, but I wanted to also switch into the fact that we had all these shelter clinics going, and we're trying to figure out how you can integrate medical and psychiatric and oral health care and behavioral health care, et cetera, into this very complicated population that tends to be very peripatetic. And we started realizing that all these shelter clinics were great, but there was a small but very important subgroup of the homeless population that was living outside and not coming into the shelter, even though there was a bed for them. And in Boston, by the way, all the shelters except for 1 don't care if you're a drunk or so, you don't have to be sober. There's no sobriety requirement to come in. You can't use once you're in the building, but you can come in at all. So we realized that people dying were those people outside, and with the help from the Department of Public Health, funding from the Department of Public Health, Pine Street Inn was able to begin operating this van back in 1986, which brings soup and sandwiches and blankets to people outside. And I think these are the people that run the van. This is an older picture now, but they were my heroes in those days. They're people that all had experienced, fragile housing. Many were in recovery. Many had been homeless at some point. But this was their full-time job, and they were out every night from 9 at night till 5 in the morning, scouring the streets of Boston, meeting and getting to know the people that are out there. And they were bringing them stuff. So I had the privilege of riding on this van on Mondays and Wednesdays for many of these last 37 or 38 years. And it's how we've gotten to know the people that live outside. We piggyback on the trust these folks earn every night by painstakingly being patient with everyone out there. So this was not a couple Mondays ago when we were outside. It's freezing cold. There's a woman who's been sleeping out since I started in 1986 in the North End on benches. we've been trying to lure her in, not able to get her in. This man who you may recognize him, he often shows up around town, and I've been trying for years to get him to come in, but he's happy to just stay outside, even in a snowstorm. But then we started to realize that we could do some effective care for these folks, even though it didn't feel right at first. But the nurses on our team, we have a team with I work with Dave, who's the other doctor here, and there's a psychiatrist on our team, and we're all, and a nurse practitioner, PA, and a nurse and a recovery coach. And our job is to sort of look at the street people as our panel of patients and share in the care of them. And our nurses challenged us, Dave and myself, about what's so sacred about the clinics that you can't, that you have to do something inside a clinic that you can't do out on the street. And with a lot of help from them, we realized that about 80% of everything we do in the clinics, at least from a medical perspective, this doesn't apply to oral health, obviously, you can do outside. So this is Dave taking care of an 84-year-old woman who's got terrible heart failure. She won't go anywhere near the hospital, but she lets us weigh her, change her medications, examine her, talk to her right there at South Station. And she loves doing that. And, we were able to pretty well manage her heart failure in an outpatient setting. By getting out there. I'm sorry, my things are not advancing here. And let me see if I can get this. The other thing that I just wanted to share with you, this is Jim Bonner, a full-time psychiatrist, many years. He recently retired. And he was a seasoned psychiatrist who started to realize that for people that he thought were resistant to care, if you go out and meet them at McDonald's or get to know them outside, you can do an awful lot of good care. And so he does his prescribing, his therapy, and his chatting with people. This is an example at McDonald's where this person prefers to be. And most of these are folks he realized won't go to anything that says psychiatry or mental health, but they'll sit and chat with you and talk about everything once they trust you. And so he broke through for us and taught us a lot. We also learned that we can do shots on these are flu shot season. Most of the folks on the street, much to our surprise, were not resistant to vaccinations and stuff. A few are very paranoid, won't do it. But this is Jill, our physician assistant, during flu shot season, giving everybody, this is at the public library and outside the public library, giving that. And then we learned some telemedicine, and I don't want to bore you with this, but this was a rash that, this man had been in the emergency room 5 or 6 times. He lived under a bridge. He was really annoyed with us because we never could cure it. He thought it was scabies, but it didn't get better with all the scabies medicine. So we took this picture back in 1998 or 9, I can't remember which, and I sent it to Ernesto, who's our dermatologist. And I said, Ernesto, what's going on here? And what I knew was, this looks like scabies a little bit, but if you look around his neck, he's got all these nodules. He's got these nodules around his neck. I didn't know what that was. So Ernesto wrote back within minutes and said, look, we went over this when he was one of my teachers when I was training. He said, we know this a lot. He said, this is not scabies, this is nummular psoriasis. I had no idea. It turns out dermatologists can make a pretty accurate diagnosis 80 or 85% of the time with a good picture. And when they can't, that's when you got to bring people in. So he told us what to do. This was this man after a couple months. This guy, by the way, now thinks I and our team are the best doctors that ever existed, even though we're only doing what Ernesto told us. But it was a great way to engage him. But we've learned that you can effectively use some of the tools on the street that we thought were only for much more advanced worlds. We often fail, and I just wanted to show you, this was a lady who we ran into on the streets who had been hiding from us, and we wouldn't let us look at her. She had a scarf in front of her all the time. We finally could have looked at her mouth. This is a pretty involved squamous cell carcinoma of her mouth. This is a woman who was a nun for many years, living in a convent, and had left several years before and just did not want anybody to see this. But you can see it gets complicated out there. And finally, let me stop here. The last thing we had to do, and I wanted to share with you, is they insisted that we be part of the hospital. They didn't want care that was fragmented from the mainstream. So we had to always be part of the hospital. So we always had clinics at Boston Medical Center and at Mass General. And then our doctors have to, attend on the wards and do the usual stuff that turns out to be really great for us and kind of good for our system. So, we have a regular street clinic at MGH it's every Thursday, but COVID has of course changed everything. We have clinic every day of the week, Monday through Friday, but the street was made to be on Thursdays, and we have coffee and donuts. We try to make it a nice place. The hospital's great about not caring that somebody comes right off the street unshowered, all that. think it's still the only hospital-based homeless street clinic in the country, by the way. It's been going since for the last 25 years. And it's our lifeblood because we have full access to specialty care. We have full access to, imaging and all the things you might know. And it's the place where we can do the more intense things we need to do. But anyway, I think I'm going to stop there. And I have a ton of other stories to share with you, but I think I'm going to leave it and see if there are any questions that I might be able to answer. Because I have this dread fear, like having been through medical school, of boring you to death, and I do not want to do that. So if it's okay, Jane, I don't know what the easiest way to take questions would be.
Great. Well, as Dr. O'Connell said at this point, we welcome your questions. Dr. O'Connell, one thing I'm really intrigued by, and maybe you could speak about this a little bit, is how it came to be that the community was driving what the programming would be like. I mean, there obviously had to be a lot of stakeholders that were supporting the community. You mentioned the mayor and several others that might have helped bring about this Robert Wood Johnson funding for this program. I'm just really curious how the stakeholders got together and enabled the community to be driving what the programming might look like.
Yeah, it's a great question. And I think we were, when I think back, so I'm a resident at the time, so I have nothing to do with this. This was all 1984. And the Robert Wood Johnson gave these grants to mayors around the country. They were 4-year grants. And they recognized an important thing, that while homelessness has to be solved at a national and state level, the day-to-day issues of homelessness show up on the mayor's desk. So when somebody's acting up downtown, somebody calls the mayor's line. So the foundation was saying, we want to help mayors. We want to give them a chance. And there were 19 cities, Boston being one of them, that got these 4-year grants. But the condition they made was that the mayors couldn't just do what they wanted. There needed to be a coalition of stakeholders. So that was a requirement, interesting requirement. And it happened to be in 1984, when AIDS is on the ascendancy, we've got a TB outbreak going, homelessness is going crazy. So mayors were really focused on wanting that grant. And so Mayor Flynn, who was there at the time, invited the advocates to City Hall. 88 of them showed up, and they met during the winter of 1984-85. And they came up with a plan, and they went to Hale and Dorr, which is the big legal firm, and got a document that the mayor had to sign with the advocates. And it said just that they had to be involved in the planning, the implementation, and the governance of the program. And then all those things that I've been relating to were kind of codified there. So I think it was an accident of time. It was the right time, the right place. But to this day, so when we have board meetings, it's the homeless folks on the board meeting that really drive the discussion when it gets out of control. We've never been able to do anything that they don't clearly approve. And that's been great for us. And I realized we lucked out, because I would never, I grew up with boards like the hospital, that was not consumer driven very much, and right. This one really is.
Right. Well, that's a fascinating background, and the accident of time, one wonders whether COVID will provide a similar type of catalytic mechanism to change how care is provided for certain populations. We have a couple of questions from the audience which relate to that. What do you think are the biggest challenges currently in getting dental care to the homeless population? And then how do we engage more dentists in providing care, in addition to the work that you have been doing?
I have become a huge advocate for changing the financing for oral health care, because if you focus just on our little narrow part of the world, take care of homeless people, what you begin to realize in stunning and stark relief is that Medicaid pays very little that goes on above the neck. So we can do anything we want with almost everything else and be reimbursed for it. But for us to set up an oral health clinic like we've been doing, which we love, we lose our shirts every year. You cannot with volume, increased volume, make up the loss. You guys know this very well. It's just not reimbursed. Same for psychiatry. So when you think of, if anything, we need psychiatric care, we need oral health care, and we can't pay for that. So why do I think there are not many programs around the country doing it? It's because it's just not currently reimbursed by CMS, Medicaid, Medicare. So that would be my first thing, is to advocate for getting better dental oral health care reimbursement, for federally qualified health centers, for hospitals, whoever. But it just, needs, because most cities, homeless people have no access to dental care still. If you don't have a Medicaid expansion, you know, our friends in those states are just toss their hands up because you can't get it. That's one thing. The other thing that I would say, so that's a problem, we should advocate for that. I have another subtext to that I'll share with you in a moment. But the other thing is I've been struck by how, you know, the dental students, particularly the Harvard dental students who we've gotten to know best, are fabulous. And, you know, and when they get exposed to something like that, it's kind of what they really love doing, or they want that to be some part of their life. And we've been struck by how, look, most of our clinic has been run by the enthusiasm and the commitment and the involvement of students who are working with our stuff. So I just would, if anybody's, you know, looking to have a kind of complicated oral health rotation, come and work with us. It's really fabulous. And I think, you know, all 4 of our current dentists were, 3 of them came from Harvard School of Dental Medicine. Another one came from BU. And they're, you know, they just get exposed when they were students and really like what they're doing. Our limitation, of course, is we can only, you know, we're lucky to have 4, you know, we only had 1 full-time staff. Now that we have 4, we think we're great, but they're overwhelmed. But fabulous. And can I tell you this? Can I tell you a selfish thing? I don't know if anybody's asked this in that question, but I worry a little bit about, you know, there's the healthcare angle for homeless people, which is, you know, the burden this population has of co-occurring medical, psychiatric, oral, and substance use problems is huge, and most people have all of those. What we really are desperate for is more figuring out how to get more care to that, more care. The problem that is going on from a policy perspective right now is that people have gone into the world that home housing is really the solution to this. And in fact, the solution to homelessness is not housing alone, but housing with a lot of support. The problem that I see is that when I see hospitals doing their community benefit, or people doing it, they'll put it into housing. And I keep saying, why don't you put it into dental care? That's so, you know, that's you stay in our lane and put it into dental care or psychiatric care, the stuff we can't get, and let HUD and the other policy people get the housing going. But we lose out to that, you know. Several hospital systems have put several $1 million into a housing program, but they won't put a cent into oral health. So I try to subtly push people to think about that, you know, or even though I don't want to get in the way of solving any homeless problem, I just think we have so many people who are desperate for care right in front of us. And the housing that we need to do is going to take 10 and 15 and 20 years to be able to take effect. So that's a bias of mine. So let me stop there.
It's really fascinated to hear you talk about the team-based approaches to care, and wondering how the dentists who are working with your clinics, how they integrate the dental care with some of the other types of care that is being provided. You also mentioned trust as being a big factor, and the community needing to want to know their providers and understand something about their history, especially if you're trying to create a team. What are those dynamics like? If you need multiple providers who need to get to know a patient, especially if it's someone who doesn't want to come in often.
And that's a really challenging and important question. What we've learned sort of in building a team, at least from a medical and psychiatric perspective, we've learned that the ideal way to do it is to have full-time people who are dedicated to the care of this. In the old days, we might have somebody who had 10% time here or 10% there, and that never seemed to work, because when you really needed them, they were at their other job. Even though we love that, that's not a criticism, but we've learned that the optimal. So the team I work on is a full-time psychiatrist whose panel of patients is the same panel I take care of. So it's not that they have, you know, 400 people they're caring for over there and 20 in our thing. Everybody, and so they're with us every day, and we're integrated in that sense. And so it's a doctor, 2 doctors, a nurse practitioner, and a PA. We're all taking care and sharing fully in the care of a panel of patients. I might add, one of the things that homeless people beat me up for, and I was horrified, was they would not allow me to work alone. I always had to work with a nurse practitioner or a physician assistant and a caseworker in the early days. And I could not have my own panel of patients. I shared that panel with them because they were hedging their bet about continuity because they didn't want me. I was going to be there for a year to get to know all these people. They'd share with me. I'd get to do whatever I can. And then a year from then, I'd up and go and do my career somewhere else. They hated that. So they wanted to be sure I was working in a team where the person I was caring for also was cared for by the nurse practitioner and the caseworker. So if I left, they still had a home, a medical home. So I think that's the theme we've tried to keep up. The problem with dentistry is that we can't bring a dentist. We don't have enough dentists to bring out with each of our teams. So we have to work, but our communication becomes key. I'll tell you just an aside, what has been just stunning to me about how effective our dentists have been, what they do is they make sure anyone we see, if I'm out on the streets or we're out in any of the shelters and see somebody with dental pain, they will see them right away. And what that does, interestingly, because people have terrible, they have terrible pain from abscesses and all these things, and you can do a lot to help that pain. And they see them right away, and then those people become their apostles in the rest of the world. So once somebody says, God, I went down there and I was in terrible pain and God, they fixed it and they were really nice, then everybody wants to go. And that's how I think they've formed their team and trust. The second thing they do is everyone who gets admitted to McGinnis House, our respite program, is seen for an oral health check, just as it's kind of a courtesy. And that's how they get to know repeat people pretty well. So they
It's really interesting. Just going back to your point about Medicaid and picking up on this theme of a medical home. Do you think that integrating oral health into Medicaid and accountable care organizations would be a way to help facilitate access for the homeless community?
Yes, I do. And when I speak, I realize there's a way of looking at the big picture, but when I look just at homeless, like people living in shelters and on the streets, who aren't going to access easily they could open up the gates for people, but these folks are not going to access it. So you always have to have a targeted response. So when I think of the targeted response, if Medicaid, and we are part of an ACO now, so we're part of the MGH and the Boston Medical ACO, and that has all sorts of potential for opening up more oral health care for us. So yes, I think that is a really important way to go. And I would just put a little caveat on that, is that this population tends to need a slightly different version of that than what I would say the mainstream population needs. And just being able to recognize that has been kind of hard for ACOs because they're trying to do it for the whole group and it's hard to concentrate. But it's a great way to go.
So we have a question about the most common oral health issue that you see. You talk about, one person coming, receiving great care, and then all the friends coming. What are the most prevalent issues and concerns?
Oh, boy, you're going to embarrass me on this one. It's a great question. And when I would have to ask our dentist, what is the rank of things going? What I can tell you is one of the really common things is people have broken teeth and lost teeth, and fitting dentures has been one of the real issues for us. And I'm guessing we do hundreds and hundreds of dentures for people each year. And that, for me, when I think back of what's visible and radical, that's people who go in are afraid to smile and come out and they are smiling and can face the world. And boy, they are so grateful for that opportunity. And it, we've learned how to subsidize those pretty well. And that just makes a big difference in a person's life. Probably much more than anything we do as internists or psychiatrists.
Oh, we've heard that often. One of my favorite quotes actually is from Dr. Lisa Thompson, who was working with a group in Bolivia, actually, helping a geriatrics program with denture care. And she told me the story of an older woman who came in, received dentures, and was so excited. She had a big smile, and her first words were, "Now I can find a husband." But right, having that ability to smile and interact with people, just makes a difference in your social relationships, your potential for all sorts of interactions, whether it's with friends, family, care providers, and others. I think you're absolutely right. That's one of the most important things that we can do, is help give people back that confidence and their ability to interact and smile, because it says so much about who you are and your state of being. So if you were to give some words of advice to our students in terms of trying new and different things or thinking about their career, what would you recommend? Or if we have students who would like to get more involved with your work, how could they go about doing that?
First of all, let me speak more. COVID has kind of cast a pall over everything. So, if we think just to the end of COVID, which I hope is just around the corner, and we can open up things again, we have, just come down and just visit the clinic would be one great thing. Come, we can set it up for maybe a group of students can come and see and talk to Colleen and the others. And then when there's available rotations, please feel free to do them. I wish we had more opportunities, but when you only have 6, operatories, we wish we had clinics in all the shelters the way we do the medical clinics, but we don't. But we're growing, and this is an important time. I think what I hope I can convey, because I didn't know what I was doing when I first started, but now that I look back, all I can say is you as dentists have so much to offer people who would be so grateful to get it, that those opportunities are immense. So just that, somebody who's not been able to smile for their life, you can get them care. You can get painful teeth, cavities filled. These are people who could not get their cavities done. You probably know all too well, when I first started, if somebody had a cavity that was really hurting, their only option was to go to the emergency room and get the tooth pulled. So they end up with all these missing teeth that nobody's doing. So then all hell breaks loose.
We might have lost you there. Okay, now you're back.
Did I freeze? I'm sorry. I think I might
have
frozen. I'm sorry. So ignore what I just said. Okay.
We actually have a comment here from Mary Casesso that there are many homeless children and families in the community. Do you work with schools at all to help provide care for homeless children and families? Just thinking about some of the photos you were showing, it seems like most of your work is geared towards adults.
Yeah, and forgive me, we do have a part of our program that's all the family program, and it's I would have given you a totally different talk based on that. But it's a great question. And what we do is we do dental checks regularly in all the shelters. And we have just down the street now, not far from you, where Bright Horizons is opening a new clinic that we're going to run. We're going to have hopefully dental care as well. But we do not go to the schools, because the schools have sort of their own system of care. But we try to see any homeless child who's in the shelter system or in the old motel and hotel system. We would do at least dental checks for them. We couldn't always do their care. Well, the nice thing about children's care is it is reimbursed. So when we see people, you can actually build up a practice on the reimbursement in Massachusetts. You can't do that with adults, but with the kids you can. So the answer is no, not the schools, but we do the shelters and where the folks live, where they live with their moms and pops.
Okay, thank you. Yeah, Mary mentions doing Cambridge Health Alliance working with the Everett Public Schools. So it seems like there are many different organizations helping to try and reach this vulnerable community.
No, there are. There's some spectacular, and I hope you know there's spectacular programs doing that, and they're really wonderful. So in different towns, I've been exposed to many different ones. It's great.
And so I think one thing that will sort of stick with me after today's presentation is your comment about hospitals and community centers wanting to put money into housing, which I think is fantastic, but being less interested in putting money into other types of care, particularly types of care like dentistry that are not funded by public insurance programs. And so I'm going to think a little bit on how we might start negotiating with some of our collaborators in the community to raise that issue and start thinking about who might be targeted for raising what kinds of dollars and managing what kinds of programs, because I think perhaps as a School of Dental Medicine, that's a place where we might be able to bring some attention, awareness, and perhaps some change.
Thank you. And if we could talk about that someday, that's a really interesting topic for me.
Okay.
We have, I'll just share with you one thing. So we do tons of home visits now. Our team too so for the longest time, people living on the streets never qualified for housing. And in 2004, after we've been following some people for 25 years, they went to the top of the line with the new low threshold Housing First and other programs, which are fabulous. It's all the permanent supportive housing. But it turns out that when you look at the subpopulation of chronically homeless people, who are the ones that they're targeting for housing now, and if you really look carefully and follow them over time, simple housing doesn't work. So everybody looks, it's about 80% of people are still in housing after a year. When you follow them for 5 years, it's down to about a third. If you look at 10 years, almost nobody's still in housing. So the lack of support once they're in housing, I think, haunts us. And the other problem is the housing is often in terrible areas. It's not the kind of housing we ideally should build. So there's it's still a wild open field of, we don't know much. It makes sense. Housing should be part of healthcare, and is absolutely. But for our population, the mortality rate once in housing has been 50% over 5 years.
Wow.
And the amount of support they get goes down and down and down and down. Because it's like victory. You get somebody into housing, you claim victory, and then move on. So we're trying hard to figure out how to keep it's like the institution of the mentally ill. It was a great idea, when they got out of the hospitals into the community with supports, but the community supports were never funded. And where did they end up? On the streets. So I'm a little nervous we're paralleling that by naively assuming housing is the answer. You can't answer it without housing. So I'm not housing should be a right to every single human being.
Absolutely. But I think the point that you're making is that there's a whole safety net of support that needs to continue. It's not one element. There may be, elements that at one time or another receive more priority than others, but maybe it's, having a coalition of stakeholders who are working together and trying to ensure that all aspects of that safety net, whether it's social services or healthcare services, that it's all, continues to be woven together to keep people whole and as successful and healthy as they can possibly be.
I agree.
Well, wonderful. This hour has just really flown by, Dr. O'Connell. We can't thank you enough for joining us this afternoon, and we look forward to opportunities to join you down at the Healthcare for the Homeless program at one of your clinics, have some of our students and faculty, I hope, back when circumstances change. And this has just been a wonderful conversation, and we're so appreciative of the work that you and your team do. And just thank you from all of us.
And a huge thank you from all of us, because I can't tell you how much we have, how much we've gained from your involvement in our program and from the dentists coming and being part of all of this. So please come and join us. You've been a miracle for all of us. So thank you.
Absolutely. Take care.
Take care now.
Have a great day.
All the best.
Thank you. You too. Bye-bye.